Welcome to our webinar on Sepsis Bundle highlights from ACOG District II. This webinar is being recorded and will be available on our website. Today's speakers are Dr. Debra Bingham and Dr. Lisa Nathan. Dr. Debra Bingham is the founder and executive director of the Institute for Perinatal Quality Improvement, or PQI. Dr. Bingham is a public health leader, educator, author, and consultant with over 30 years of experience. She has successfully led hospital, state, and national improvement efforts and held key leadership positions. Dr. Bingham is a registered nurse with a Master's of Science degree in perinatal nursing from Columbia University and a doctorate in public health from the University of North Carolina at Chapel Hill. Dr. Lisa Nathan is an associate professor and director of labor and delivery and inpatient obstetrics at Jack D. Weiler Hospital, Montefiore Medical Center. She is the co-chair of ACOG's Maternal Sepsis Workshop and steering committee member of the State Motherhood Initiative. She is the founder of the Global Women's Health Program for the department and has received grant support from the Einstein Global Health Center and the U.S. Fulbright African Regional Research Program. She completed her Maternal-Fetal Medicine Fellowship at Montefiore Einstein as well. In addition to her clinical and administrative duties at Montefiore Einstein, Dr. Nathan is a consultant to the New York City Department of Health, where she serves as the senior maternal mortality case abstractor for the Maternal Mortality Review Committee. So I will now turn it over to Dr. Bingham.
Hi, everyone. So nice to be with you today. I'm going to just give a few updates on PQI and let you know some of the things that are coming up and some of the things that we are doing. First off, just want to remind you all that the mission of the Institute for Perinatal Quality Improvement is to expand the use of improvement science to eliminate preventable morbidity and mortality and end perinatal racial and ethnic disparities. And so all of our work is focused on achieving this mission. We're very grateful to have such an active and supportive executive advisory board, as well as an editorial advisory board. And we're so grateful to the members of these boards for all of the guidance they provide us. So one of the reasons we were formed, or I should say the main reason, is because of the rise of maternal mortality in the United States. And also we're not doing that great in infant mortality as well, in neonatal mortality. But so we're focused in on creating solutions, creating education that will help eliminate these disparities, as well as eliminate preventable maternal deaths and injuries. We are very focused on eliminating disparities in perinatal outcomes. And this slide shows that there is the biggest disparity is between Black women and white women, but also non-Hispanic, American Indian, or Alaska Native women also suffer a lot of disparities in the United States. We've also had a rise in maternal morbidity over just a very short time period, almost a 200% increase from 49.5 to 144. Most of that is related to blood transfusions. So why do more? We know that we need to make sure we get the blood transfusions done to save lives, but we also have questions around, well, what are the main reasons for this? And one of the associated causes of this is the overuse of C-sections. So as you can see from these key data, morbidity and mortality and disparities are a focus of our work. With that in mind, we created the Speak Up Against Racism and the Speak Up Implicit, Explicit Bias, Racial Bias Education Program. Speak Up is an acronym as well as a mnemonic, and it can apply across all disciplines, across all topics. We focus in our examples into the perinatal space. And you can see the acronym: set limits, practice and prepare, express your concerns, apologize, keep improving, uncover and learn, persuade others. We're very honored to have Renee Byfield as the program director for the Speak Up program, and so grateful for all of her leadership in this area. Speak Up is part of dismantling racism as a journey, not a sprint. And our approach is really applying a QI lens to this very difficult problem to solve, but also keep in mind, we believe that these disparities can be eliminated. So there's whole pathway. There's a whole number of steps we are encouraging everyone to go through. The first step is to become a Speak Up champion. The second step is to, the next level is to become an ambassador, and then eventually to become a faculty member. We have the whole program's laid out on our website. Feel free to look at that at your leisure and let us know if you have any questions about that. We also created a 28-day anti-racism challenge, which has reflections, learning activities, and also actions for each day of this 28-day period. It's on the website, open access. You can start your journey at any point to do this 28-day challenge. And we also have online modules that go along with the Speak Up program, the why, pledging, and how modules. So those are also often used in combination with the actual virtual education. So in addition, sorry, 1 second. There we go. We have the first ambassador course is being launched in July, on July 15th. In order to attend this course, you must have completed the Speak Up Champion virtual education. But we already have a nice group of people coming to this course, and they will then be teed up to be eligible to apply to become faculty of the program. We also do PQI profiles. We like to highlight people doing really important work. And so if you have some cool things you're working on, and these lessons, these QI profiles are really, perinatal QI profiles are really to help inspire you, help everyone learn from each other in a very effective way. One of the initiatives, as I mentioned, the high rates of blood transfusions as well as other morbidity is related to overuse of C-section. And one of the things that we know will reduce C-section is freedom of movement, supportive vaginal births, and so intermittent auscultation is, we have an educational program that has simulation-based education, and a lot of, it's still pretty new. Would love to, if you're interested in learning more about this education program, let us know. It's really to make it easy for a team to get the practice they need to use intermittent auscultation without trying to learn on the patients themselves. So it has 5 simulation activities within this education. And we're also hiring, we're looking for a new project manager. If you know someone who might be interested in this flexible hours position, we would love to have them submit their resume and cover letter to us at info@perinatalqi.org. So QI saves lives, and that's why we are formed, and we are very excited. We turned 5 this month, and so we're having a little celebration on June 30th, and we will have some free giveaways at that party. And some of that will be, one of the giveaways will be, you'll get free access to the intermittent auscultation education course if you show up to our party. But we're also just going to have some fun together. So there'll be a little dance party section of that. Now, without further ado, I'm really excited to turn the presentation over to Dr. Nathan.
Great, thank you so much. Good afternoon, everyone, and thank you, Dr. Bingham and the Institute of Perinatal Quality Improvement for inviting me to speak today on such an important topic in maternal health care. Can you go ahead and advance to the next slide? So as was mentioned, I am a member of the Safe Motherhood Initiative, and I'm going to be presenting our sepsis and pregnancy care bundle today. Next slide. So I have no financial disclosures. And I thought we'd start today with a simple question, which is, what is the ultimate goal of overall sepsis care during pregnancy? If we had to sum it up in just a few words, it would really be early diagnosis and timely initiation of treatment, because this is incredibly crucial to survival. Earlier diagnosis, though, is only achieved when we have a defined screening tool and combine this with a standardized workup and a standardized diagnostic criteria. And this then, coupled with timely intervention, is what will reduce the chances of the disease process progressing from infection or sepsis, progressing to that truly life-threatening septic condition. And performing these steps translates to optimized patient care, data collection, and reporting that's done objectively, which of course is so important, as you all know. And this then allows us to compare results to make future informed decisions relative to care in pregnant populations. Next slide. So as you're all well aware, and as Dr. Bingham was just reviewing with us, we have an absolute crisis in this country with way too many women dying largely preventable deaths during pregnancy or the postpartum period. Now, specific to infection and sepsis, the data is showing us that pregnancy-related maternal deaths due to infection and sepsis have actually risen since 2011 and is now the third most common cause of maternal mortality in New York State. The other two leading causes being embolism at number 1, 29%, and hemorrhage at number 2, and then infection is accounting for 14.5% of all deaths. The leading causes of pregnancy-related deaths in the US, we see infection or sepsis as the second leading national cause of death at 12.7%. Next slide. And this becomes important because as maternal deaths due to hemorrhage and embolism continue to decrease, mainly due to availability of practice bundles and increased awareness of the warning signs, we're going to see that infection is going to become a more significant cause of maternal mortality. Next slide. So we're going to start with some basics. Next slide. Maternal health or maternal sepsis is defined by the World Health Organization as a life-threatening condition defined as organ dysfunction that results from infection during pregnancy, childbirth, post-abortion, or the postpartum period. Next slide. This quote by Barton and Sabai really captures the essence of maternal sepsis and its importance. As they say, sepsis onset in pregnancy can be insidious, and patients may appear deceptively well before rapidly deteriorating with the development of septic shock, multiple organ dysfunction syndrome, or death. The outcome and the survivability in severe sepsis and septic shock in pregnancy are improved with early detection, prompt recognition of the infection, and then targeted therapy. Next slide. As with all of ACOG's Safe Motherhood Initiative care bundles, we attempted to group the elements of our maternal sepsis bundle into the 4 R's of readiness, recognition, response, and reporting. Sepsis, however, is a tricky condition, and it didn't really nicely fit into these categories. So what we did for this bundle is group them broadly into 2 big groups, one for readiness and recognition together, and then the second for reporting, response and reporting. Next slide. So starting off with our first group of readiness and recognition, the utilization of the maternal early warning system is a crucial part. Next slide. So what is the maternal early warning system? It's defined as a set of specific vital sign and physical exam findings that prompt a bedside evaluation and/or a workup. It's a screening tool, so a positive Muse screen would then prompt an intervention, which is the provider coming to the bedside and evaluating the patient. They use their clinical judgment, they make a differential diagnosis, and then would implement the appropriate bundle. And in our case, we're going to be talking about the sepsis bundle. And the goal of this is the prompt and timely identification and then treatment of women who are developing a critical illness. To be clear here, this is an early warning system for any type of medical emergency, not specific to sepsis. So you would do your evaluation and it would prompt you to the appropriate bundle or the appropriate next steps for what you feel is the emergency at the time. Next slide. So Muse is a general term, the maternal early warning system. There are different types of systems. It encompasses a number of similar types of systems. And what we look for in an early warning system as a screening test is something that is going to have both simplicity as well as a balance between sensitivity and specificity. That's the ideal screening test. Next slide. And to satisfy these 2 criteria, the SMI, the Safe Motherhood Initiative, recommends that an institution or a maternity ward adopt the modified early warning criteria. This is a specific type of Muse. And the reason that we feel that this is the best muse to adopt on a maternity ward is because it's simple, and it also has a good balance between specificity and sensitivity. It's simple in that just one abnormality is a positive screen, and then it has a nice balance between sensitivity and specificity because that one abnormality needs to be present for greater than 20 minutes. Again, that combination then gives you a positive screen. Next slide. So the first step of our care bundle addressing the readiness and recognition elements is having a screening system in place. So if your facility already has one, the staff considers it's appropriate for your clinical environment and infrastructure, by all means continue to use it. These are the various types of muse that are out there, and these are some of the references for where you can find more information about them. Next slide. If, however, your unit or facility does not already have a muse, we advise that you use this modified MUC, which I'll be showing you on the following slide. As I mentioned, it has been studied and it's been shown to have a good balance between sensitivity and specificity, and at the same time, very simple to use. And this becomes important when we think about all the alarm fatigue, right, that all providers experience these days with electronic medical records. So when choosing a system, if you don't already have one in place, it's important to consider the ease of use by your staff, avoiding alarm fatigue, and then also just what is your unit's clinical environment like? What's the infrastructure like? Next slide. So this slide outlines our suggested system. As I mentioned, it's called the modified MUC, or maternal early warning criteria. And these are just the various criteria. I won't go into all of reading each one of them. But again, a positive screen is just having one of these criteria be abnormal and have it sustained for greater than 20 minutes. It's a simple tool, and it has a good, excellent balance between the sensitivity and specificity. So what happens when you have a positive screen? Next slide, please. This outlines the next step being the prompt bedside evaluation by a provider. And again, you would look then at what is your specific muse abnormality. So what vital sign was abnormal? And then what is the clinical presentation of the patient? What type of risk factors are present? Any additional tests that may already have been done on the patient? And the provider puts all of this together and determines what do they think is the most likely etiology. And this would then lead you to your following workup. And again, today we're going to be talking about the sepsis bundle. Next slide. So you come to the bedside and you've done your prompt bedside evaluation, and your specific muse abnormality when we're thinking about sepsis is most of the time an abnormal temperature or tachycardia. But of course, if the patient is very septic already, you may see abnormalities in any of those criteria: hypotension, altered mental status, etc. You would then look at the clinical presentation, and for sepsis, again, more likely things that you may see, signs would be things like respiratory urinary infections, uterine tenderness, or foul-smelling vaginal discharge. There are multiple risk factors, obstetric risk factors that you might find in the patient's history during this prompt bedside evaluation, things like prolonged labor, prolonged rupture of membranes, fetal tachycardia. The patient may have had an examination indicated cerclage, for example, or have a history of multiple UTIs during the pregnancy. And again, you would then also look at some tests, additional tests that may have already been done on your patient. So this constitutes the bedside evaluation. And again, based on all of this, we then think that sepsis is the most likely diagnosis, and we'll move on to the sepsis bundle within the SMI bundle group. Next slide, please. I really like this slide, and I put it here because it's a nice visual to see how this then is incorporated into the big clinical picture. So if your patient is infected and has risk factors, lab tests consistent with it, with that infection, the clinical progression is then you'll see some changes in the clinical status. And these you'll pick up on your physical exam or the patient complaints. And this is all part of this detection period when your maternal early warning system should be screening positive for the patient and prompting that bedside evaluation. So during that period, this is when you have that opportunity to make the diagnosis and actually stop the progression, the clinical progression from infection to sepsis and then septic shock. So during that detection incubation period is when your screening system should go positive and you have a bedside evaluation by a provider who will then begin the standardized sepsis workup. Next slide. Next slide, please. So what is that workup algorithm? So the sepsis workup, first of all, should be initiated as soon as possible, right? Because the goal is therapy should be commenced within 1 hour of suspected sepsis diagnosis. This has been shown multiple times to be the #1 factor in reducing mortality from sepsis. So you have your physical assessment, as we talked about. We're going to be looking at mental status, respiratory rate, oxygen saturation, blood pressure, heart rate, and urine output. In addition, if you have an idea of what may be causing the infection, targeted imaging studies should be ordered to aid in that diagnosis. In addition, you'll be doing cultures as clinically indicated. It could be blood cultures, could be urine cultures. You'll also get a CBC, a complete metabolic panel, coagulation profile, and a lactate. And all of this will help us to be able to make the actual sepsis diagnosis. Next slide. So what are the leading causes of maternal sepsis? This depends on the timing during which a patient may become infected and develop sepsis, whether it's the antepartum period, when septic abortion, chorioamnionitis may be more common, or pyelonephritis. It can happen intrapartum or immediately postpartum. Chorioamnionitis, again, is one of the leading causes, or endometritis, of course, pneumonia, pyelonephritis, or a wound infection. And then post-discharge, we know that patients can also go home and develop sepsis at home and come back to our emergency rooms, with any of these being the most common etiologies for that timing of the sepsis diagnosis. Next slide, please. So keeping all of that in mind, you have now done your workup and you're waiting for your results to come back to be able to make your diagnosis, but you're monitoring the patient in the meantime. So what we have here is just some guidelines for how to monitor that patient, what the time frame should be, and then additional considerations that you would have. So if the patient is pregnant, you would want continuous fetal monitoring for sure. Pulse oximetry should be continuous as well. And then blood pressure and temperature, you're doing those every 30 minutes. Checking hourly urine output and mental status as well should really be a continuous aspect that you are evaluating for. Next slide, please. So now we're going to talk about how we make that diagnosis. So you've been monitoring this whole time and waiting for your results to come back. Next slide. And to clinch a diagnosis for sepsis, what is required is that you have the positive screening test first. So you have to have one of those abnormalities, at least one of them in the vital signs. Then you've sent your blood work off and you get a result that is consistent with end organ damage, evidence of end organ damage to one of these systems. So pulmonary system can be the respiratory rate being greater than 30, or the patient may be hypoxic. The cardiovascular system, again, these are all vital sign abnormalities. Coagulation profile, this is lab work, of course, where your platelets may be under 100, INR greater than 1.5, or PTT greater than 60. Liver, bilirubin greater than 20. You can have abnormalities in your renal function, your mental status, as well as lactate. And lactate is defined as greater than 2. One thing I will say as a caveat here is just to remember that labor can increase lactate in and of itself. So if it's borderline right around 2, you really need to use clinical judgment, because that can be just due to labor. Next slide, please. So I do want to also mention that there is a subgroup of patients who are going to be at increased risk that may not actually meet the criteria for sepsis, but that you are pretty sure that this person is infected and very sick, and even if they don't have sepsis right that minute, they're going to be developing it very soon. So these patients are going to require closer surveillance. They may even require a higher level of care depending on where the patient is located. And you can identify these patients by those who have any 2 abnormalities of those listed here. So maternal temperature abnormalities, a heart rate, white blood cell count, or bandemia. So if they have any 2 of these and they don't actually meet the diagnosis for sepsis, you still want to be watching these people extremely closely and repeating your evaluations and repeating laboratory tests. and watching them closely or potentially moving them up to a higher level of care. Next slide. So now for diagnosis of septic shock, right? This is different than sepsis. We define shock now as hypotension, where you need vasopressor support to maintain a MAP greater than 65, and you have an elevated serum lactate that's at least 4 or more. Next slide. So now we're going to go into management of sepsis. Next slide. So the initial sepsis management is really a triad. No specific one should happen first, really as much as you can do these simultaneously. But it's the triad of antibiotics, fluid management, and calling appropriate consults as per your institution's protocol. So this will then be followed by considering whether or not perhaps you need to transfer your patient to a higher level of care. It's going to be, you're going to also be doing source control if you know what is causing the infection. You may have to also add vasopressor support. Depending on the patient's clinical situation, you could consider antenatal steroids for fetal lung maturity, consider magnesium sulfate for neuroprotection if it's appropriate, VTE prophylaxis, and then of course you'll evaluate the need for delivery. So next slide. So now going into this in a bit more detail, for that triad that we talked about, antibiotics is the first one. We say to start this within an hour of sepsis suspicion, because we know, again, from data that delayed antibiotics more than an hour leads to increased mortality. These antibiotics should be broad spectrum, and then you can narrow and focus them once the pathogen and the sensitivities are identified. Next slide. So this here is just a list of the sources of infection and recommended antibiotics. I'm not going to read through this list, but of course we can share the slides. And I would just say for this slide, we do advise just consulting your hospital's antibiogram just to make sure that you're using the appropriate antibiotics for the type of sensitivities that you might have in your area. Next slide. Fluid management is the other big part of that initial triad for caring for patients with sepsis. So for sepsis-induced hyperperfusion, the recommendation is to administer an initial bolus of 30 cc's per kilogram. This should be IV crystalloids. So it should be about 1 to 2 liters at minimum, and this should happen within 3 hours of diagnosis. Fluid approach is going to require some clinical judgment and might also require adjustment based on your clinical situation. So we just warn that there is a risk of fluid overload when people are septic. About half of septic patients will be fluid responders and half will not, and there is a risk of fluid overload in some patients. Particularly, these are patients with additional comorbidities, so things like preeclampsia, cardiovascular disease. Also, patients with obesity need closer monitoring. So in those circumstances, depending on your facility, you may need to transfer the patient out for a higher level of care or involve your ICU or critical care folks at that point. As far as this fluid management, after that bolus, you then want to reevaluate your patient's status after that and see if they're responding or not. Again, then potentially moving them to a higher level of care or the ICU. Next slide. So as far as septic shock, how do you manage these patients? We just advise if your patient is showing evidence of septic shock, then you need to get a critical care consult and get those team members involved in their care. And this is definitely something, depending on the hospital system that you're working within, that you need to have colleagues. You need to set up protocols, which we'll talk about in a few minutes, for how to care for those patients in lower resource settings. Next slide, please. So source control. After cultures have been obtained and your antibiotics have started, you then want to determine if it may be clinically appropriate to drain something, to evacuate, potentially remove something surgically. So identify and exclude as rapidly as possible if there's a very defined source that is causing the patient to become septic. Next slide. Now, there's going to be a group of patients that we call non-responders. So for patients who haven't responded to your antibiotics, and we're talking over a few days, not, we're not looking for a huge response immediately. But if you are seeing that your patient is not responding and it's been about 2 days, you have to start considering, is there some other rare complication that may be going on? Things like an intra-abdominal abscess, for example, that is just not going to respond to IV antibiotics, and you're going to need to surgically drain that. Potentially, there's septic pelvic thrombophlebitis. In these cases, you'd have to add anticoagulation, for example, or potentially a patient had surgery and there was a bowel injury where timely re-exploration is key. Endomyometritis with myometrial abscesses is another one of those rare things that is only going to be treated surgically, and so that patient may require a total abdominal hysterectomy. Next slide, please. The other thing to consider that we had mentioned earlier in that initial management slide is that there are patients who will need to get transferred out to a higher level of care. So this could mean out of your hospital system, out to a different hospital, or just out of your floor up to or down to an ICU setting. So these patients are typically the medically complex patient, someone with significant comorbidities, those patients who have developed hypotension, defined as a MAP below 65, despite your fluid resuscitation or the need for administration of vasopressors, someone who's persistently hypoxic, despite all of your care, they remain hypoxic. This person needs to be transferred to a higher level of care, as well as those who have altered mental status. Next slide. Now, VTE prophylaxis is something that is incredibly important. As you know, it's one of the leading causes, VTE, one of the leading causes of maternal mortality, and something that an infected pregnant patient is going to be that much more at risk for. And we can't forget this in the overall care of the septic patient. While we're worried about our antibiotics and all the rest of it, we can't forget that they also need to be on some sort of either pharmacologic prophylaxis or potentially just with sequential compression devices. So an important thing to remember, and again, this is one of our other care bundles that you can also find on the ACOG District II website. Next slide. So continued management. So what do you do for those patients who don't require, that higher level of care? So they're not going to the ICU, they're not getting transferred out, but they're definitely sick, they're definitely septic. You've started all of the appropriate management steps, and then what do you do after that? So antibiotics, you're going to narrow the spectrum once your sensitivities are available. For your fluid management, after correction of the hyperperfusion, you're going to be decreasing down your fluids, give them maintenance fluids only at about 100 to 150 cc's per hour. And you should be including some PO fluids at this point. You'll want to continue checking labs every 6 to 8 hours for the first 24 hours after diagnosis. Pulse ox should be continuous for that first 24 hours after diagnosis. You're going to continue your strict ins and outs. You're going to do this hourly for the first 12 hours, and then we advise going to Q2 hours if it's normal. And then you'll monitor vital signs per your unit protocol. And delivery time, again, will be based on routine obstetric indications. Next slide. So those higher level care considerations, individual institutions should really evaluate existing policies and create new ones as necessary that are going to align their available resources to safely manage a critically ill or postpartum patient. And this is important because, as we had mentioned before, if you determine that this patient is becoming critically ill and is not responding, there needs to already be in place a way for you to get that higher level care for the patient. It shouldn't be something that you're having to sort of figure out and put together in the moment. And as far as delivery planning, obstetric indications should be used to direct delivery in most instances. And optimal fetal status is generally predicated on optimizing the maternal condition as much as possible. Next slide. So now we're just going to mention some of the patient and provider education, the case debriefing, and the multidisciplinary review, which is part of our bundle. So the sepsis education, as you all know, is just incredibly important. So frontline maternity staff, so the nurses and the OBGYNs, of course, need to be educated on this, but so do our ER physicians. There's a lot of patients who are going to be coming in through the ER and we won't even know about them, and potentially they could be missed and treated inappropriately, given there's so many changes of pregnancy, and we know the vital sign abnormalities can be different and more pronounced. It's important that the ER physicians are internists as well, those in the inpatient and outpatient, the community-based hospital system, where these people will be our frontline maternity staff, that they are all educated in how to identify sepsis in a pregnant or recently postpartum patient. We also advocate educating rapid response teams. Pharmacists, anesthesiologists are very important, but then as well, some of the administrative heads, right? Our hospital administrators, our department heads, they also need to know about the importance of having protocols in place and having streamlined processes within the hospitals and with interdepartmental, so that we can care for these patients in a timely fashion. And then, of course, educating patients and families is incredibly important for the patients who potentially go home and become septic at home in the postpartum period or the antenatal period. So we are working with the Sepsis Alliance and End Sepsis, which was formerly the Rory Stoughton Foundation for Sepsis Awareness. This is work that ACOG is doing to spread awareness to patients and families. Next slide. And this here is just a debriefing form, a screenshot of what we make available online, and it just will help folks to conduct multidisciplinary reviews of your cases. It's very important to always review all of your septic shock or any other type of emergency on your labor floors. This allows us also to monitor process metrics and outcomes in a standardized fashion, and keeps you in compliance with your hospital protocols. Next slide. So just a few conclusions for you. Again, early recognition, action, and targeted management are key to risk reduction and successful clinical outcomes in maternal sepsis. So preparing in advance, multidisciplinary team-based approach to care will help ensure availability of resources when the need arises. Evaluation and diagnostic criteria need to account for alterations in maternal hemodynamics, respiratory function, and renal function due to pregnancy physiology. And increasing evidence indicates that standardizing care improves patient outcomes. Next slide. So because of this, we advocate that using a maternal early warning system to screen all patients and then incorporating a robust risk factor analysis for each patient is incredibly important. And then always maintain a high index of suspicion for maternal sepsis. Use your standardized sepsis workup algorithms and diagnostic criteria, because they are key to achieving timely clinical intervention. Again, timing is incredibly crucial. Cultures should be taken, antibiotics should be started within an hour of the suspicion of sepsis. So thank you so much for your attention. I just wanted to conclude here with a screenshot of our website where you can download the care bundles. So all the ones that we have, and sepsis is our newest one. You can find all of them here at this website. Next slide. We also have an app that's free, and it's constantly updated, and it's incredibly helpful. So I advise anyone who hasn't seen this to take a look at it and download it. It's very helpful on the floors. And I think we have time for questions at this time. These are just my references.
Yeah. I'll just, so it's in the recording, then we'll have the next set of reference too. So thank you so much, Dr. Nathan, for your presentation. It was excellent. We already had a lot of comments and people wanting more information. So, and just to remind everyone, this is being recorded, and we do make the recording available through the website. So I have, oh, somebody wants me to go back to the AAP slide. I'll do that. Is that the right one? Let's see. Nope. Anyway, this one, I think. All right, let me know if that's not the right slide. If you have questions, please put them in the chat. We would love to have you we want to be able to answer your questions. I have some questions for you in the meantime while we wait for others to submit their questions. What do you think are some of the best tips you have around implementing a maternal warning system? And because I know that's a lot of work, and that's the first step towards identifying, an issue. And I do, when I was in California several years ago, and I read every death that occurred in a 3-year period, almost every single death had abnormal vital signs. If on retrospect, you could see like the patient telling you with their vital signs that something was pending, those vital signs would not be attended to in any kind of effective manner. And then we ended up with having to do a mortality review, right? So I think that's such a critical component of what you brought up, and just wondering if you have had other suggestions for how to implement warning systems.
So full disclosure is that we are still in the process of doing that ourselves.
It's hard, right? I mean, it's really hard. Yeah.
It is not easy. And, I think the way that we are doing it, I can tell you the way that we're doing it, which was very thoughtful and purposeful. We, of course, have a multidisciplinary group that is working on it together, which I think is key, right? We can't just be a bunch of doctors determining something and then pushing that forward, or a bunch of nurses, whichever way you look at it. So we have both. We also have an IT person working with us. We have residents not come to all the meetings, but we get their input, and when they can, they come, because all of these people are stakeholders, of course, and we know alarm fatigue is probably the #1 concern. So we want to make sure that this is something that people will respond to and take seriously. What we have done here is also combined it with some retrospective analysis of our data, right? So looking at our patient data, and we have someone within our IT who is going back and applying the criteria, the early warning system criteria.
That's smart. Yeah.
Looking to see, okay, retrospectively, we know who had sepsis, would it have gone off for her? And then also just doing it in general to look at how often would it have gone off for a regular OB patient who did not have any complications. And so that's part of what we are doing. It's a lot, it's intensive and a lot of work, but we work with some people, some demanding people here who want the data and want to know and make sure, it's one of those things. So but of course it's also helping us to have a very accurate, because we're probably going to not use exactly the MUC and probably tweak it a bit, just basing it on the data from our specific institution. So.
Well, that's really interesting. Thank you for sharing that. We have another question that says, where do they find the debrief tool that you showed? I think, is it in the toolkit that?
Yes, so all of that stuff should be available if you just Google ACOG SMI care bundle, or you can put in sepsis bundle and it'll take you to the website there. And then when you click on the sepsis bundle, it will have a slide deck, and it's part of that.
Then there's another question that says, in a non-ICU patient, do you recommend transferring a postpartum woman back to L&D?
So that again is sort of a unit dependent thing. So, for example, where I work, we bring someone who's sick like that back to our PACU on the labor floor. It's really dependent primarily on your nursing ratios on your postpartum unit and the level of care that could be provided, because the patient's obviously going to need more frequent vital sign monitoring. And that whole, if you remember that slide that talked about the continuous monitoring that needs to be done. So it'll depend, if your postpartum unit can handle that, then they can stay there. But most of the time, I think most institutions, most wards need those patients to be back on a labor floor.
Yeah. But I think it depends on the facility and all of that, right? So good points. I'm going to ask another question around implementation. So I know this is a really relatively new bundle for the state of New York. Can you describe So it's out on the website. Do you do any active conversations with other hospitals, or do you know of other hospitals that have been implementing the bundle, and how that's been going?
So yes, it is very new. I know that Kristen DeVries is on this call, so she may be able to answer that best because she's the head of our District II effort on this. It is very new. We do offer to go to hospitals that are wanting to implement it, and folks from the Safe Motherhood Initiative will go and help with implementation, provide the slide deck like we'll give the lecture on, which is similar to what we're doing now. And then we do hold meetings where people, hospitals will send representatives and we'll meet in a large group to discuss some of the issues around implementation, but we haven't had that yet for sepsis because it's quite new.
Cool. And there's a question from Kathy Jones. She says, we are working on a maternal sepsis BPA that will fire appropriately for this patient population and support proper evaluation and treatment. Have you had experience with a BPA that worked well?
We're still in that process, so I don't just yet. That's the big question. That's the big question, but yeah, I can check back with you after we've figured that out.
Yeah. So let's see if there's any other questions. It says, we have offered hospitals tailored implementation visits and on the bundle of their choice. However, the pandemic has thwarted some of this. Yes. I think that's across the country, unfortunately. And the sepsis bundle was rolled out last May, so we have not had the opportunity to go on site and teach this one. So that may have come in from your colleague that you were, yeah. So what else do you like? What would like here? We've got a whole group of people wanting to improve outcomes with sepsis. You've highlighted some of the key points. So one of the first things you're working on is getting your muse and assessing how your patients do, you know, who fell through the cracks or what conditions they had. What are some other tips, some QI tips for the group and for as implementing, like how to implement the debrief tool? Has that gone well? Any of the other things that you mentioned that you could highlight some tips and insights for the group?
Sure. I think one tip that I would say that we have started that is helpful is having order sets. It might be something simple that everyone does, but in case, you know, that is helpful to someone, I will, you know, I think it's important to highlight that you can create a sepsis order set. And a lot of hospitals will then, their pharmacies, like this bumps the line. So anything ordered within, or the same for the lab, it bumps the other orders that have come in to the lab or to the pharmacy. And so you can get your lab results faster and you can get your antibiotics up faster. So that's a key thing to think about. And it's an easy thing to start, right, you know, tomorrow kind of thing. And the other thing, two things I would say, one is in line with that, is the incredible importance of making sure you've had the discussions with all the stakeholders within your hospital, right? So as I said that, my mind just went straight to, yes, but we had a meeting with the lab and we had a meeting with the pharmacy. You have to have those meetings and get everybody on board, of course. And that goes for, you know, the other pieces of the bundle as well, as far as like moving patients up to a higher level of care. That there has to be a working understanding between departments as well as within the hospital administration overall. And what goes along with that then is education, which is the next huge thing, right? The nurses need to be educated fully on this. The residents need to be educated like every single step of the way so that the patients don't fall between the cracks.
Pamela Lesser put in a question. She said, or a comment, she said that they have a code sepsis team and that sepsis team responds to help implement bundle elements in a timely manner. And this includes lab and pharmacy along with the doctors and nurses. So
that's fantastic.
Yeah, that's great, Pam. One question, you had talked about the reviews and you have somebody doing like a thorough chart review, but do you do like regular maternal morbidity and mortality reviews? And do you have like some kind of assessment tool to I'm sure it's more robust and includes more than sepsis, but do you have like, as you do those hospital level reviews, helping really hone in on lessons learned and opportunities for the future?
So we do use the debriefing tools that ACOG has. We do also do just in-depth case narratives for all near misses or significant maternal morbidity, and of course for mortality as well on those rare circumstances. But and those case narratives have, it's really like a very detailed chronology, like with the timestamp on each step. And I do want to stress also, which I forgot to mention, how important the patient's voice is in all of this. So the evaluation of that patient, what the patient is complaining of, those are very important pieces, and we include those into the narrative too, because knowing when the patient started to complain of something and then what the response was, all that helps with the debriefing and looking for ways to improve.
Do you include the patient in the debrief?
We don't include at this time. We don't include them in the actual debriefing.
Yeah, so years ago when I was at A1, I helped create like I took what I had done at CMQCC, and then when I went to A1, I created a new debrief tool, and it included debriefing with the patient family, and people did implement that and found that really insightful, but I think, yeah. So how do you get the patient voice? You have someone interview them or talk to them?
Our nurses will record in the moment. So when the patient is recovering in PACU, for example, our nurses do a lot of in quotations of what the patient complains of, or of course in their assessment, they'll write how she looked visibly, what she was complaining of, all of that. So that's the piece that's in there.
That's the part that you get.
Yeah.
Okay.
When you go and ask a patient, how are you feeling? Like when your evaluation should be more than just the physical exam, right? It should be talking to the patient in the overall assessment. So that's what I was referring to. And
okay, cool. All right, we have one more question. And Kathy Jones made a comment. I think she's responding to the comment by Pam. She says they have the same and it is great. So I think that's that rapid response sepsis team. And Kathy, if I'm wrong in that assumption, let me know. But Tammy Leaf says that any advice you could give as far as stakeholder buy-in when implementing Muse in our rural hospital without an OB intensivist, our OBs are resistant to the at the bedside request. And the nurses easily dismiss high BPs or heart rates as she is in pain.
So that's the $1 million question. I always feel like education and data is the strongest weapon that you have. I also think buy-in is important, and the best, my experience with this, I've never worked in a rural setting outside of Africa, but I would say like sitting down with these folks together with the data, like if you can do some review of some of the patients that have been missed, for example, that is something that no one can dispute, right? And you could show where in that whole timeline, if there had been an earlier intervention, there could have been a different outcome. And so I think that's always my first go-to, is trying to show people where the difference could have happened and how it could have improved patient outcomes using data from your own institution. But sitting down together and reviewing it together, and also asking them, do you have a different solution? Because this is an unacceptable outcome. It's a preventable outcome. So what other solution can we come up with if this isn't something acceptable to you? But it's difficult.
Well, yeah, it's hard. But one of the things is I also think sometimes we're not willing to learn from others. Like, why should we all make the same mistakes, right? So if there are data to tell us that this is a big issue in the country, we know it's a leading cause of preventable deaths. I'm not sure you need to wait until you have your own tragedy, right? But also do your own case reviews too, to learn from how we could have done better. That's why I was asking about if you had a way in which, like that form you used to confirm, did did we follow our own protocol? So I think probably that first step is really working on the protocol with everyone. I think the at bedside, how important is the at bedside evaluation, or is there, because that's the part that's really hard in a rural setting. I have worked in a rural setting, like the nurses are also like, do they really need to get the doctor out of bed? It's like, in other words, you know, like have them drive there. So that's, do you have any insights or any references around when it is so critical to be at bedside if you're in a rural setting?
I mean, I can't speak 100% to the data on it. I know there's data surrounding the need for that, and for that to happen within 20 minutes is what, because, you know, they've studied these various forms of the Muse and how they are most effective. And that's where that advice comes from. But who is this provider who comes to the bedside? You know, it can be a physician assistant. It could be a nurse practitioner.
Could be an ER doc, right? If they, you know, like anybody who's unhoused, right? So, right. Yeah, so it's been, anyway, I didn't mean to cut you off. So it's been studied to show that at the bedside is important, that actual physical exam by the physician.
Yes, some of those references will have the actual, there is one specific study that looked at MUC specifically, and some of that information is in there.
Cool.
In the reference slides, yeah.
Well, thank you so much. I know we're at time. Well, there is one last, let's see, let me just make sure. It looks like I have one last question. And we have 3 minutes. Any advice you could give us? Oh no, that's the same question. Okay, so I think, Dan, did I get all the questions? Did I miss anything? I think I got everybody's questions. And thank you so much, Dr. Nathan, for your presentation. It was highly valuable. We had, you know, we will be posting this on the website, and we will be sharing the recording to anyone who has registered. They will get a link to the recording. And again, thanks for all your time, Dr. Nathan. Really appreciate it.
My pleasure. Thank you so much for having me.
Yeah, such important work. Thanks everyone for coming. Talk to you all later.
Thank you.